A healthy human heart is a masterpiece of fluid dynamics, a perfectly sealed, dual-pump engine. Blood flows side by side, strictly divided by solid muscle walls. But when structural flaws form during fetal development, that perfect seal is compromised. Often, these congenital anomalies don't manifest as immediate catastrophic failures. Instead, they act as silent, hidden volume leaks that a patient can carry, completely unaware, into adulthood. Take the atrial septal defect, or ASD, a physical hole bridging the right and left atria. Clinicians identify it by a specific acoustic signature, a fixed split S2 sound. Unlike normal breathing fluctuations, this murmur remains perfectly static. Looking at this clinical guide, because it's often asymptomatic, there is a rigid threshold. The moment right ventricular enlargement is detected, intervention is mandatory. The hole must be closed before the damage becomes irreversible. Moving down to the heart's lower, high-pressure chambers, we find ventricular septal defects, or VSDs. A hole here forces fluid through a high-pressure gradient, creating violent turbulence that doctors hear as a loud, continuous, hollow systolic murmur. This chart reveals the strict mathematical threshold for managing a VSD. Surgical intervention is required when the shunt ratio, the amount of blood bypassing the system, calculated as QP over QS, exceeds 1.5. If that ratio is ignored, the excess blood continuously forced into the lungs triggers pulmonary arterial hypertension, tearing apart the delicate pulmonary vessels. These leaks aren't confined to the chambers. This diagram outlines anomalies in the great vessels. A patent ductus arteriosus occurs when a fetal vessel fails to close. It causes differential cyanosis. Unoxygenated blood turns the legs blue, while the right hand remains pink. The clinical rule here is uncompromising. Any persistent left-to-right shunt through a PDA creates a prime environment for bacterial infection, meaning it requires immediate closure to prevent fatal endocarditis. While shunts create danger through swirling volume leaks, these obstructive lesions threaten the heart through raw, restrictive pressure. These physical choke points in the arterial pathways put immense structural strain on the cardiovascular architecture. Coarctation of the aorta is a severe structural pinching of the body's primary exit artery. It forces the heart to push against a massive bottleneck, and it's frequently found alongside a two-leaflet or bicuspid aortic valve. This pulse wave graph shows a highly specific physical symptom, a radiofemoral delay. The patient's leg pulse arrives later than their wrist pulse. The exact surgical tipping point triggers when the pressure gradient exceeds 20 millimeters of mercury. Just below that level, within the heart itself, we find subvalvular aortic stenosis. Here, an abnormal fibrous ring creates a tight choke point right underneath the main aortic valve. This blockage generates a roaring crescendo-decrescendo murmur. That sound is the acoustic signature of a high-velocity jet stream tearing through the narrow opening. These pressure blockages are dangerous because of how they degrade the surrounding tissues. That aggressive jet stream physically batters the delicate valve leaflets situated above it, inevitably causing severe aortic regurgitation. We now reach the final tier of severity. In these complex cyanotic defects, the entire cardiovascular architecture is severely miswired, forcing the heart to perform mechanical tasks it was never designed for. As this clinical sketch illustrates, tetralogy of Fallot is characterized by a harsh right ventricular outflow murmur. The resulting structural changes give the heart an iconic boot-shaped silhouette on an X-ray, but the true clinical threat of this condition emerges years later. The late-stage complication is chronic pulmonary regurgitation, where backward blood flow causes massive, dangerous dilation of the right ventricle. Looking at this anatomical diagram, we see the ultimate anatomical paradox: congenitally corrected TGA. In this condition, the heart's ventricles are physically transposed, effectively swapping their positions. This creates a catastrophic mechanical flaw. The thinner, weaker right ventricle is suddenly forced to act as the primary, high-pressure systemic pump for the entire body. It's a role it cannot sustain, leading to a high risk of massive systemic failure and electrical blockages. These complex cyanotic defects force biological tissue to absorb continuous mechanical forces it was never meant to handle. Survival here relies entirely on rigorous, lifelong monitoring. If the early-stage shunts we discussed earlier are ignored, the system eventually breaks down entirely. Decades of unrelenting pulmonary pressure will finally overpower the heart's architecture. This triggers Eisenmenger syndrome. The pressure in the lungs becomes so immense that the shunt physically reverses direction. Instead of oxygenated blood leaking in, deoxygenated blue blood floods outward into the body's main circulation. This illustrates systemic deoxygenation. Patients develop extreme digital clubbing and central cyanosis. The pulmonary vessels are too far gone. Closing the original hole causes immediate heart failure. As the bold text warns, corrective surgery is strictly forbidden. This is why recognizing those precise clinical thresholds is so critical. Monitoring pressure gradients and shunt ratios is the only defense clinicians have to intercept a malformed architecture before it reaches the irreversible point of no return.